Welcome back to Bugs and Beyond, your one-stop shop for everything infectious diseases. Before we jump into today's fascinating topic, let's take a moment to cultivate some joy. Think about a recent moment that brought a smile to your face, big or small. Maybe it was a beautiful sunset, or a delicious meal, or a heartwarming conversation. Let that positive feeling wash over you. Did you know that tapping into positive emotions actually primes your brain for optimal learning?
It's true. Positive emotions enhance cognitive functions like memory, attention, and creative thinking. It's like giving your brain a supercharge.
I love that. So we're not just learning about infectious diseases, we're setting ourselves up for a truly enriching experience.
Hmm.
Now, for those joining us for part 2 of our deep dive into intra-abdominal infections, or IAIs, get ready to explore the crucial aspects of management and antimicrobial therapy. Last time, we laid the foundation, exploring what IAIs are and how they develop. Today, we'll delve into the strategies we use to combat these often tricky infections.
And it's important to remember that IAIs aren't just a concern for healthcare professionals. They're more common than you might think. And understanding the basics of how they're managed can be empowering for anyone.
Absolutely. Knowledge is power, especially when it comes to our health. So let's unpack the cornerstones of IAI management. What are the key elements that clinicians focus on when tackling these infections?
Managing IAIs requires a multifaceted approach. It's not just about prescribing antibiotics. It's about addressing the problem from multiple angles. We can break it down into three main pillars: source control, hemodynamic resuscitation, and antimicrobial therapy.
The three-pronged attack. I like it. It sounds straightforward. But I have a feeling there's a lot more to each of these pillars than meets the eye. Let's start with hemodynamic resuscitation. What exactly does that involve? And why is it so important in the context of IAIs?
When you have an infection brewing inside your abdomen, it can trigger a cascade of events that disrupt your body's internal balance. One of the major concerns is fluid shifting out of your blood vessels and into surrounding tissues and spaces. Due to inflammation, this fluid loss can lead to a dangerous drop in blood volume, a condition called hypovolemia.
So it's not just the infection itself that's a problem, but also the body's response to it.
Exactly. Hypovolemia can be a real threat, leading to inadequate blood flow to vital organs. Hemodynamic resuscitation aims to restore that lost fluid volume, typically through intravenous fluids, ensuring that your organs continue to receive the oxygen and nutrients they need to function properly.
It's like replenishing the body's internal supply chain, making sure those vital organs don't experience a shortage. But what if IV fluids alone aren't enough to stabilize a patient? Are there other measures taken in severe cases?
In critical situations, patients might require medications called vasopressors. These medications help constrict blood vessels, effectively increasing blood pressure even when the fluid volume is low. It's like giving the circulatory system an extra boost when it's struggling to keep up.
Fascinating. So we've covered hemodynamic resuscitation, stabilizing the patient's circulatory system. But what about tackling the root cause of the problem? That's where source control comes in, right?
Absolutely. Source control is like putting out the fire before you start cleaning up the mess. It involves addressing the underlying cause of the infection, which often means surgical intervention to drain infected fluid, remove damaged tissue, and essentially eliminate the source of contamination.
So it's like containing the damage and preventing the infection from spreading further. I imagine timing is crucial in these situations.
You're spot on. Ideally, source control should be achieved within 24 hours of diagnosis to minimize the risk of complications and improve patient outcomes.
It's like removing a splinter. The sooner you get it out, the better. Okay, so we've addressed hemodynamic resuscitation and source control. Now, let's talk about the weapon we often associate with fighting infections: antimicrobial therapy. I know this is where antibiotics come into play, right?
Exactly. Antimicrobials are essential for eliminating the bacteria that are fueling the infection. But choosing the right antibiotic isn't always as straightforward as it might seem. It involves careful consideration of various factors, almost like a detective piecing together clues.
Okay, I'm intrigued. I've heard the term empiric antimicrobial therapy used in this context. What does that mean? And what factors do clinicians consider when making these initial decisions?
Empiric means that we're choosing antibiotics before we know the exact culprit, the specific bacteria causing the infection. We're making an educated guess based on the available information, like the patient's medical history, their risk factors, where the infection originated, and local patterns of antibiotic resistance.
So it's like a calculated risk, using the best available information to choose the most likely effective antibiotic while waiting for more definitive test results. What are some of the key considerations when assessing a patient's risk level in this context?
We consider factors like their age, overall health, and the severity of the infection. For example, someone with a perforated appendix and signs of sepsis would be considered high risk, even if they're otherwise young and healthy.
That makes sense. So it's not just about their baseline health status, but also the specific circumstances of their infection. Once we've assessed the patient's risk, what's the next step in this antimicrobial puzzle?
Next, we need to think about the types of bacteria most likely to be involved. This helps us decide whether to use a broad-spectrum antibiotic, which targets a wide range of bacteria, or a narrow-spectrum antibiotic, which is more targeted in its approach.
I remember learning about this. Broad-spectrum antibiotics are like casting a wide net, while narrow-spectrum antibiotics are like using a laser to target a specific culprit. But I imagine there are pros and cons to each approach.
Precisely. While broad-spectrum antibiotics can be effective initially, they can also disrupt the balance of the gut microbiome, potentially leading to unwanted side effects. That's why we aim to use the narrowest spectrum antibiotic that will effectively target the suspected bacteria once we have more information.
So it's a delicate balance between effectiveness and minimizing collateral damage to the gut's delicate ecosystem. What other factors come into play when selecting the right antibiotic?
The location where the infection was acquired is another important clue. Infections acquired in the community are often caused by different bacteria than those acquired in a hospital setting, which tend to harbor more resistant strains.
Oh, right. I've heard about those antibiotic-resistant bacteria that are becoming a major concern. They can be incredibly challenging to treat.
They are. And that's why we also take into account local patterns of antibiotic resistance when making our empiric antibiotic selection. We want to make sure we're using an antibiotic that has a good chance of being effective against the bacteria circulating in the patient's community or hospital.
It's like a constantly evolving chess match, trying to stay one step ahead of these resilient bacteria. So we've chosen our antibiotic, taking into account the patient's risk, the likely bacteria involved, and local resistance patterns. What about the dosage and duration of treatment? Are there general guidelines for that as well?
Absolutely. Dosage and duration are critical for successful treatment. Too little antibiotic and the bacteria might survive and develop resistance. Too much, and we risk unnecessary side effects and contribute to the growing problem of antibiotic resistance.
It's a delicate balance, finding that sweet spot that maximizes effectiveness while minimizing potential harm.
Exactly. And it's important to remember that antibiotic treatment should always be guided by a healthcare professional. Self-treating with antibiotics can be dangerous and counterproductive.
Absolutely. Always consult with a doctor to ensure you're receiving the appropriate treatment. Now, I know there are many different types of IAIs, each with its own unique characteristics. Are there any specific examples you'd like to highlight that demonstrate these management principles in action?
Two common types that come to mind are appendicitis and diverticulitis. They both involve inflammation in the abdomen but have distinct features and often require different treatment approaches.
Perfect. Let's start with appendicitis. I know it involves the appendix, a small finger-shaped pouch attached to the colon. But what exactly causes it to become inflamed, and how is it typically treated?
Appendicitis usually occurs when the appendix becomes blocked, often by fecal matter, a foreign object, or even a tumor. This blockage leads to inflammation and infection, which can quickly worsen if left untreated.
And I imagine that rupture is a serious concern.
Absolutely. If the appendix ruptures, it can release bacteria into the abdominal cavity, leading to peritonitis, a life-threatening condition. That's why prompt diagnosis and treatment are so important.
So what's the typical course of treatment for appendicitis? Is surgery always necessary?
Appendectomy, the surgical removal of the appendix, is the standard treatment for appendicitis. Thankfully, advances in surgical techniques have made appendectomy a much less invasive procedure than it used to be. Laparoscopic appendectomy, which involves small incisions and the use of a camera to guide the procedure, is now the preferred approach in most cases.
Okay, so laparoscopic appendectomy is the go-to treatment. But you mentioned earlier that there's growing interest in using antibiotics alone for some cases of appendicitis. Can you elaborate on that?
Yes, there's emerging evidence suggesting that antibiotics alone might be a safe and effective option for certain patients with uncomplicated appendicitis, particularly those who are low risk and have early-stage disease.
That's fascinating. So in some cases, we might be able to avoid surgery altogether. What are the factors that clinicians consider when deciding whether antibiotics alone are appropriate?
It's a decision that's made on a case-by-case basis, taking into account the patient's overall health, the severity of their appendicitis, and the preferences. It's important to note that this approach is still being studied, and more research is needed to confirm its long-term safety and effectiveness.
It sounds like we're on the cusp of a paradigm shift in the way we approach appendicitis, moving towards a more personalized approach that considers a wider range of options. Okay, let's shift gears and talk about diverticulitis. Can you remind us what causes this condition, and how does it differ from appendicitis?
Diverticulitis involves inflammation or infection of small pouches called diverticula that form in the wall of the colon. These pouches are quite common, especially as people age. In most cases, they don't cause any problems. But sometimes these pouches can become inflamed or infected, leading to diverticulitis.
And what causes these pouches to form in the first place? Is it something we can prevent?
The exact cause of diverticula formation is still debated, but a low-fiber diet is considered a major contributor. When your diet lacks fiber, your stool becomes harder and more difficult to pass, putting strain on your colon. Over time, this chronic strain can cause weak spots in the colon wall to bulge outward, forming those pouches we call diverticula.
So a high-fiber diet is like a superhero for colon health, helping prevent those pesky pouches from forming in the first place. But what happens when these pouches do form and they become inflamed or infected? What are the typical symptoms of diverticulitis?
The most common symptom is abdominal pain, usually on the left side, where the sigmoid colon is located. Other symptoms can include fever, nausea, vomiting, constipation, or diarrhea.
It sounds like the symptoms can be quite varied. How do clinicians diagnose diverticulitis and differentiate it from other conditions that can cause abdominal pain?
The diagnostic process usually starts with a physical exam and a review of the patient's symptoms and medical history. Then, imaging studies, like CT scans, are used to confirm the diagnosis and assess the severity of the inflammation.
Okay, so we've diagnosed diverticulitis. What are the treatment options? You mentioned earlier that surgery isn't always necessary. What factors determine the best course of action?
You're right. Most cases of uncomplicated diverticulitis can be effectively managed with a combination of antibiotics and bowel rest. This involves sticking to a clear liquid diet for a few days to give the colon a chance to heal.
So it's like giving the digestive system a timeout, allowing it to rest and recover.
Exactly. Once the symptoms improve, patients can gradually transition back to a regular diet, with an emphasis on high-fiber foods to prevent future episodes.
So antibiotics and a temporary liquid diet are the first line of defense. But what about more severe cases, or those that don't respond to this initial treatment? When is surgery considered?
Surgery might be necessary if the diverticulitis is severe, causing complications like an abscess, a perforation, or a fistula. It might also be recommended for patients who experience recurrent episodes despite conservative management, or those with a weakened immune system.
So surgery is reserved for more complicated or persistent cases. It's fascinating how the management approaches for appendicitis and diverticulitis can be so different, even though they both involve inflammation in the abdomen. What are some of the key differences in their surgical management?
In appendicitis, the goal of surgery is typically to remove the appendix entirely, as it's a relatively small and non-essential organ. In diverticulitis, surgery usually involves removing the affected portion of the colon, either reconnecting the healthy ends or creating a temporary or permanent colostomy, depending on the extent of the disease and the patient's overall health.
It sounds like surgical management for diverticulitis can be more complex and individualized, depending on the specific circumstances. This really highlights the importance of a thorough diagnosis and a collaborative approach between the patient and their healthcare team to determine the most appropriate course of action.
Absolutely. Every patient is unique, and their treatment plan needs to be tailored to their individual needs and circumstances.
Well said. Now, before we wrap up this part of our deep dive, I want to touch on a topic that's near and dear to my heart: prevention. Are there any lifestyle changes or dietary modifications that people can make to reduce their risk of developing these common IAIs, particularly appendicitis and diverticulitis?
While appendicitis is often difficult to prevent, there are definitely steps people can take to lower their risk of developing diverticulitis, which, as we discussed, is often linked to a low-fiber diet.
I'm all ears. What are some of the top dietary recommendations for preventing diverticulitis and promoting overall colon health?
The key is to increase your fiber intake. Aim for at least 25 to 35 grams of fiber per day. This can be achieved by incorporating plenty of fruits, vegetables, whole grains, and legumes into your diet.
Fiber is truly a gut health superstar. It helps keep things moving smoothly and prevents those troublesome pouches from forming in the first place. Any other dietary or lifestyle tips you'd like to share?
Staying well hydrated is also crucial for gut health. and can help prevent constipation, which is
Wow.
a risk factor for diverticulitis. So make sure you're drinking plenty of water throughout the day.
Right. Water is essential for life,
Hmm.
and it plays a vital role in keeping our digestive system functioning properly. What about exercise? Does physical activity play a role in preventing diverticulitis?
Absolutely. Regular exercise helps stimulate bowel motility, promoting regularity and potentially reducing the risk of developing diverticulitis. So get moving, folks.
Excellent point. A high-fiber diet, adequate hydration, and regular exercise are like the trifecta for promoting gut health and reducing the risk of diverticulitis. It's amazing how simple lifestyle changes can make such a big difference.
Absolutely. It's all about taking a proactive approach to your health and making choices that support your well-being.
Well said. Now, before we move on to part 3 of our deep dive, where we'll explore even more fascinating cases and delve deeper into the world of antimicrobial stewardship, let's take a moment to recap the key points we've covered so far.
Sounds good. It's important to solidify these concepts before we move on to more advanced topics.
We started by laying out the 3 cornerstones of managing IAIs: source control, hemodynamic resuscitation, and antimicrobial therapy. We then explored the intricacies of empiric antimicrobial therapy, highlighting the importance of assessing patient risk, considering the likely culprits, and factoring in antibiotic resistance patterns. We also dove into the differences between community-acquired and hospital-acquired infections, emphasizing the need for tailored treatment approaches.
And we discussed the crucial role of antimicrobial stewardship in combating antibiotic resistance. We need to use these powerful medications judiciously, avoiding unnecessary prescriptions and promoting responsible use.
Right. It's all about finding that balance between effectiveness and minimizing the unintended consequences of antibiotic use. We then shifted gears and explored 2 common types of IAIs, appendicitis and diverticulitis, discussing their distinct features, diagnostic challenges, and treatment nuances.
We highlighted the evolving role of antibiotics in appendicitis, the importance of a high-fiber diet in preventing diverticulitis, and the crucial role of personalized medicine in tailoring treatment to each individual patient.
This has been a jam-packed exploration of IAIs. I hope our listeners are finding this deep dive as enlightening as I am, but we're not done yet. In part 3, we'll continue our journey into this fascinating world, exploring even more intriguing cases and delving into the ever-evolving landscape of antimicrobial stewardship.
Stay tuned for more insights and discoveries.
Welcome back to Bugs and Beyond. We're diving right back into our exploration of IAIs. Before we jump into the next fascinating case, let's take a moment to appreciate the power of our own bodies. Close your eyes for a moment and bring your awareness to your breath. Notice the rise and fall of your chest as you breathe in and out. This simple act of breathing is a marvel of biological engineering. It's a reminder that our bodies are constantly working to keep us alive and thriving.
That's a great point. It's easy to take our bodies for granted until something goes wrong. But even when we're facing challenges, like an infection, our bodies are incredibly resilient and capable of healing.
Absolutely. Our bodies are amazing. Okay, let's shift gears a bit and delve deeper into the complexities of managing IAIs. We touched on appendicitis and diverticulitis earlier, but I'd love to explore those conditions in more detail. What are some of the key insights or nuances that our listeners might find helpful?
Let's start with appendicitis. As we discussed, it's an inflammation of the appendix, often caused by an obstruction. The classic symptoms are abdominal pain, nausea, and vomiting. But what's interesting is that the location of the pain can vary, which sometimes makes diagnosis tricky.
I've heard that the pain often starts around the belly button and then migrates to the lower right abdomen. Is that always the case?
While that's the classic presentation, it's not always so straightforward. The pain can start in different areas, and its intensity can fluctuate, especially in children and older adults.
So relying on symptoms alone isn't always enough to make a definitive diagnosis. What other diagnostic tools are used to confirm appendicitis?
Physical examination is always the first step, but imaging studies like CT scans and ultrasounds play a crucial role in visualizing the inflamed appendix and ruling out other potential causes of abdominal pain.
Okay, so imaging studies are key for confirming the diagnosis. Once appendicitis is confirmed, what's the typical course of treatment?
As we mentioned earlier, appendectomy, the surgical removal of the appendix, is the standard treatment. It's usually performed laparoscopically, which means using small incisions and a camera to guide the procedure. This minimally invasive approach typically leads to less pain and a faster recovery compared to open surgery.
Okay, so laparoscopic appendectomy is the go-to. But we also discussed the emerging possibility of treating some cases of appendicitis with antibiotics alone. Can you elaborate on that?
Yes. There's growing evidence suggesting that antibiotics alone might be safe and effective for uncomplicated appendicitis, particularly in low-risk patients with early-stage disease. This approach is still being studied, but it's an exciting development that could potentially change the way we manage appendicitis in the future.
It's amazing how medical science is constantly evolving, offering new possibilities for treatment. So, are we moving towards an era where some people with appendicitis can skip surgery altogether?
It's certainly a possibility. However, it's important to note that the decision to treat with antibiotics alone or proceed with surgery is made on a case-by-case basis, considering factors like the patient's overall health, the severity of their appendicitis, and their preferences.
Makes sense. It's all about personalized medicine, finding the best approach for each individual patient. Okay, let's move on to diverticulitis. You mentioned that it involves inflammation of pouches in the colon. Can you remind us what causes these pouches to form in the first place?
These pouches, called diverticula, are thought to develop due to increased pressure within the colon. This pressure can cause weak spots in the colon wall to bulge outward, forming the pouches.
And what contributes to this increased pressure in the colon?
A low-fiber diet is considered a major culprit. When you don't eat enough fiber, your stool becomes harder and more difficult to pass, putting extra strain on your colon. Over time, this chronic strain can lead to the formation of diverticula.
So a high-fiber diet is key for preventing diverticulitis.
Got it.
But what happens when these pouches become inflamed or infected? What are the symptoms of diverticulitis?
The most common symptom is abdominal pain, usually on the left side, where the sigmoid colon is located. Other symptoms can include fever, nausea, vomiting, and changes in bowel habits, like constipation or diarrhea.
And how is diverticulitis typically diagnosed? Is it similar to appendicitis?
The diagnostic process is similar. It starts with a physical exam and a review of the patient's symptoms. Then, imaging studies like CT scans are used to confirm the diagnosis and assess the severity of the inflammation.
Okay, so we've diagnosed diverticulitis. What are the treatment options? You mentioned that surgery isn't always necessary. What determines the best course of action?
For uncomplicated diverticulitis, which is the most common scenario, the initial treatment usually involves a combination of antibiotics and bowel rest. This means sticking to a clear liquid diet for a few days to allow the colon to heal and reduce inflammation. Once the symptoms improve, patients can gradually transition back to a regular diet. But it's important to emphasize high-fiber foods to help prevent future episodes.
So, antibiotics and a temporary liquid diet are the first line of defense. But what if the diverticulitis is more severe or doesn't respond to this initial treatment? When is surgery considered?
Surgery is usually reserved for more complicated cases or when conservative management fails. This might include situations where the diverticulitis has caused an abscess, a perforation, or a fistula. It might also be recommended for patients who experience recurrent episodes, despite lifestyle modifications and antibiotic treatment, or those with a weakened immune system.
Okay, so surgery is considered for more severe or persistent cases. What does surgery for diverticulitis typically involve?
It usually involves removing the affected portion of the colon, either reconnecting the healthy ends, or creating a temporary or permanent colostomy, depending on the extent of the disease. It's a more complex procedure than an appendectomy, and the recovery time can be longer.
It sounds like surgical management for diverticulitis is much more involved than for appendicitis. This really highlights the importance of taking steps to prevent diverticulitis in the first place.
Absolutely. And that's why we emphasize the importance of a high-fiber diet, adequate hydration, and regular exercise. These simple lifestyle modifications can make a big difference in reducing your risk.
Well said. Now, before we move on to our final segment, where we'll explore the fascinating world of antimicrobial stewardship, let's take a moment to recap the key takeaways from our discussion of appendicitis and diverticulitis. We've covered a lot of ground, and it's important to solidify those key points.
Great idea. Let's do a quick review.
We started by emphasizing the importance of prompt diagnosis and treatment for both conditions, highlighting the role of imaging studies in confirming the diagnosis. We then explored the standard treatment approaches, including laparoscopic appendectomy for appendicitis and antibiotics combined with bowel rest for uncomplicated diverticulitis.
We also touched on the possibility of treating some cases of appendicitis with antibiotics alone, though more research is needed to confirm the long-term safety and effectiveness of this approach.
Right. It's an exciting development that could potentially change the way we manage appendicitis in the future. And we emphasize the importance of a high-fiber diet, adequate hydration, and regular exercise for preventing diverticulitis and promoting overall colon health.
It's amazing how simple lifestyle changes can have such a profound impact on our health.
Absolutely. Okay, get ready to explore the fascinating world of antimicrobial stewardship in our final segment. Welcome back to Bugs and Beyond for the final part of our deep dive into IAIs. We've covered so much ground already, from the basics of diagnosis and treatment all the way to exploring the nuances of specific conditions, like appendicitis and diverticulitis. But before we wrap things up, there's one more crucial topic we need to discuss, one that has major implications for the future of healthcare: antimicrobial stewardship.
You're absolutely right. Antimicrobial stewardship is all about using antibiotics wisely, making sure these life-saving medications remain effective for years to come. It's a collective effort, really.
It makes perfect sense to me. We've talked about the threat of antibiotic resistance throughout this whole deep dive. And, well, it feels like a really big challenge, you know?
It is a big challenge. It really is. The overuse and misuse of antibiotics have fueled this rise of antibiotic-resistant bacteria, and they pose a serious threat to public health. If we don't start acting now to preserve the effectiveness of antibiotics, we risk going back to a time before antibiotics, when even a simple infection could be deadly.
It's a scary thought, for sure. So what can we do? How can we make sure we're using antibiotics the right way, but still giving our patients the best possible care?
It's going to take a multi-pronged approach. It involves everyone: healthcare professionals, policymakers, and even the public. One of the key principles of antimicrobial stewardship is, well, pretty simple: use antibiotics only when they're absolutely necessary. This means thoroughly evaluating each patient, taking into account their individual risk factors, and then choosing the most appropriate antibiotic, based on what we suspect or confirm is the pathogen causing the infection.
So it's about being much more strategic, more thoughtful in our approach, rather than just prescribing antibiotics for every infection.
Yeah. Right. We need to move away from this just-in-case mindset when it comes to antibiotics. Instead, we should be aiming for a more targeted, more evidence-based approach.
What about patient education? Do they have a role to play in this antimicrobial stewardship?
Absolutely. A huge role. Patients need to understand that antibiotics aren't some kind of cure-all magic pill. They don't work against viral infections like the common cold or the flu, and taking them when you don't need them can actually cause more harm than good.
We definitely need to bust that myth that antibiotics are the solution for everything. What are some key messages we can get across to patients to help them be more responsible with antibiotics?
The most important message is that antibiotics should only be taken when they're prescribed by a doctor. That's number one. We also need to explain to them that taking antibiotics unnecessarily can really mess with the balance of their gut microbiome. And that can lead to things like digestive issues, yeast infections, and other problems. And, maybe most importantly, we need patients to understand that using antibiotics incorrectly can contribute to antibiotic resistance, which ultimately makes those medications less effective for everyone.
Those are definitely important messages to spread. Well, we've talked about the importance of antimicrobial stewardship, but I want to shift gears for a moment and explore another aspect of IAIs, the role of the microbiome.
The microbiome is truly a frontier in science. It's becoming more and more important to our understanding of infectious diseases, including IAIs. We've mentioned it before, but it's this vast community of microorganisms. They live in and on our bodies, with the gut microbiome being the one everyone's most familiar with.
I love thinking about those trillions of tiny organisms living inside of us. It's this complex ecosystem that has a huge influence on our health in so many ways.
It's pretty mind-blowing when you think about it, right? And we're still just beginning to grasp all the ways the microbiome interacts with our bodies, with our immune systems, our metabolism, and even our behavior.
So how does this microbiome actually play a role in IAIs?
Think of it like this. In a healthy gut, the good bacteria, we call them commensals, outnumber the bad bacteria. That creates a balance and helps protect us from infection. But if that balance gets disrupted, well, the harmful bacteria can take over. And that increases our chances of getting infections, including IAIs.
It's like a constant battle between the good guys and bad guys in our gut.
Exactly. What's really interesting is that research now suggests that specific types of bacteria in our microbiome might actually protect us against IAIs, while others might actually increase the risk.
It's not just about good versus bad bacteria then, but also about the specific types present. Wow, that's incredible.
It is. This new knowledge has opened up so many possibilities for preventing and even treating IAIs. For instance, there's a lot of interest now in probiotics. They're live bacteria that are good for you. And the idea is that we can use them to restore that healthy balance in the gut microbiome and hopefully reduce the risk of these infections.
Probiotics, like the kind you find in yogurt and things like that, I've always heard they're good for your gut, but I had no idea they might help prevent serious infections like IAIs.
That's right. There's also a growing interest in a more drastic approach called fecal microbiota transplantation, or FMT. It's being looked at as a potential therapy for infections that keep coming back, or for IAIs that are really tough to treat.
FMT. Okay, you've got to tell me more about that.
Okay, so basically, FMT involves taking fecal matter from a healthy donor and transferring it to a recipient. Someone whose microbiome is out of whack. It's basically like hitting the reset button on the gut microbiome,
Yeah.
giving it a fresh start with a healthy community of microbes.
It's like a total gut makeover.
Exactly. It's still experimental, at least for IAIs, but early studies show that it's promising, especially for people who haven't had success with traditional treatments.
This is mind-blowing. It's
Yeah.
amazing to think that we might be able to use the power of the microbiome to prevent and treat these infections. It's a whole new world in medicine.
I totally agree. The microbiome is this incredibly complex and dynamic ecosystem, and we're really just starting to understand what it can do.
Well, we've reached the end of our deep dive into IAIs. It's been an amazing journey exploring all the details of these infections, from the very basics of diagnosis and treatment to the new and exciting world of the microbiome, and of course, the challenge of antimicrobial stewardship.
It's been such a pleasure sharing this journey with you and all of our listeners.
I want to encourage all our listeners to like, subscribe, and share this episode with anyone who might be interested. And if you want to keep learning about IAIs and the fascinating world of microbes, be sure to check out our other episodes.
We've got some incredible episodes coming up. We're exploring all the latest research and clinical insights. We're really passionate about making the science of infectious diseases accessible and, most importantly, engaging for everyone.
Thanks for joining us on Bugs and Beyond. Keep that curiosity alive, keep learning, and until next time, stay healthy.